says open. Who's looking me over? Looking me over. If I try enough, would you feel my missing piece? I can't understand why I misunderstand my own desire. If I carry on in what I know is wrong, the colors bleeding.
Good evening, ladies and gentlemen, friends of CVSKL. Thank you for joining this Facebook Live session today, which is a pure Q&A session. So I hope lots of you will send in your questions, and hopefully I can give you some answers to the key burning issues that are concerning all of you. As you know, CVSKL is a cardiac and vascular hospital. We do have gastroenterologists, we do have a nephrologist who are an essential part of our fabric, and we have not, unfortunately or fortunately, had to deal with COVID patients here. So we really, respect all our friends, cousins, friends in the front line, and in hospital. Expose the hospital and us ourselves to risk of patients who come here innocently, totally unaware that they might be carriers or in the early stages of COVID infection. As you know, it's so widely prevalent everywhere around us. So we do have full precautions here, and we as cardiologists or physicians looking after patients with cardiovascular problems are aware that there's a huge concern for patients. And infectivity, or your capacity to get infected, I think it's largely the same for everyone, whether you're a little kid or you're an elderly person, or if you've got heart disease or whatever. Your risk of having a virus fly by, decide to do a U-turn and travel up your nose or into your eye or mouth is the same for everyone. What happens to that virus and how it impacts you is what varies from individual to individual. So if you have heart disease, there's certainly a clear increased risk of something adverse happening to you. In fact, if you look at statistics and data from different parts of the world, heart disease patients have a 10% higher mortality than the average person. So usually we take 1 or 2% as a 2% as a all-comers figure of mortality risk to all comers. Heart patients have a 10% mortality rate. So yes, heart patients are at higher risk, and certain other subsets of people with other conditions also at high risk. And I'm sure we'll be going into these areas in more depth later, but suffice to say that diabetics are very high risk. Even hypertension patients, you guys who just take that pill once a day, who feel perfectly healthy, perfectly normal, and so you should. However, there is a higher risk of you getting this COVID. I mean, not picking up the infection, but having an untoward reaction to the infection. So yes, everybody's chance of getting infected is pretty much the same. And that boils down to exposure to people with it. And so everyone should try and self-isolate as much as possible to reduce risk of infection. And if you have these things, you're going to likely to have a more difficult course of the illness. So that's the first question. Second question. Very important, very nuanced question, because the question is about medication, blood pressure medication having an influence on your risk of getting the virus or suffering a bad outcome. So there is a particular class of blood pressure drug that has drawn a lot of attention, and that group is called the angiotensin converting enzyme inhibitor class of drug, or angiotensin receptor blocker class of drug. These are widely used drugs by us and by physicians and GPs for the management of hypertension, because these drugs not only reduce blood pressure, but they've also been shown to actually reduce kidney disease, heart disease, stroke, etc. So they are a very popular drug in our armamentarium now, okay? There's been scientific literature suggesting that the ACE enzyme, which is one of the key elements that help the whole cardiovascular system work and control blood pressure, the size of our blood vessels, salt and water retention, etc. This ACE, angiotensin converting enzyme, lives in the lungs, in blood vessels, in the kidney, and the lining of your gut. And there's been a question mark that hypertension patients may be more susceptible because the drugs we prescribe target these particular enzymes. And it's been shown that, sorry to get scientific here, but angiotensin is a very important hormone in this blood pressure, heart failure, cardiovascular paradigm. And angiotensin gets converted by an enzyme to angiotensin 2. Now, angiotensin 2 is the key bad guy. It causes thickening of your blood vessel walls, it causes blood pressure to go up by retaining salt and water, and it constricts the blood vessels. So by blocking the enzyme that leads to the formation of angiotensin 2, we actually have a very good drug. And this angiotensin converting enzyme inhibitors actually reduce these nasty effects of this angiotensin 2. The hypothesis is that by us blocking the angiotensin 2, you're going to have more angiotensin 1 buildup, which goes channeling to the ACE2 enzyme. And the ACE2 enzyme will then be upregulated. You get more and more ACE2 being formed because this arm is being blocked. And the ACE2 has been found to be the real gateway for coronavirus to enter our bodies. Hence the lungs, where there's a lot of ACE2 and ACE1, but if the ACE1 is not functioning, ACE2 takes over. And ACE2 actually has good effects, but more ACE2 appears, more doors open for the coronavirus to enter. So when they started seeing a lot of hypertension patients coming in, and a lot of these patients are taking these drugs, there was a question mark. Is it because of these drugs? But latter research we've seen over the last few weeks has tied no association to the drugs. Yes, the ACE2 gateway is definitely a key player for coronavirus, but there's been no clear scientific evidence to suggest that the angiotensin converting enzymes or the angiotensin receptor blocker drugs are having an impact. So if you are taking something like captopril or Coversil or perindopril or lisinopril, all these are angiotensin converting enzyme blood pressure and heart failure drugs, continue your medication, do not stop. Okay? It's been declared by all the key medical authorities that these drugs are safe. And angiotensin receptor blockers are also, by the same token, safe. So angiotensin receptor blockers would be losartan, Diovan, a lot of you probably on these drugs, Koza, olmesartan, Olmetec, all these are angiotensin receptor blockers. So this entire family of drugs are safe, and you must not interfere with that medication during this period. Okay? So that's a very important message I would like to impart on everyone who's taking these drugs. Okay, next question. Is it true that heart disease patients have a weaker immune system? That's false. If you suffer from coronary artery disease, blockages of your coronary arteries, or if you have heart failure that is not, has not rendered you really cachectic. Cachectic means your heart is so weak that there's no perfusion to your whole body, and there's a lot of breakdown of cells and muscle, and you become really skinny like a cancer patient. That's called cachexia. Now, unless you're so advanced, there's no evidence that heart disease has effect on your immunity. So things that affect your immunity are, of course, AIDS, HIV infection, certain virus infections, autoimmune diseases where your body's own cells misbehave and they attack your own organs. And very often either that condition or the drugs we use like steroids and immunosuppressant drugs, these things affect immunity, but not blood pressure or diabetes or heart disease. Okay? What happens when you do get infected is a different story. All right? So immunity is not really affected by these conditions. Right. Right. The question is, patients with cardiac diseases such as heart disease, high blood pressure, and diabetes are at risk from COVID-19 because their disease leads to poor circulation to the tissues. At risk, yes, because as I said earlier, your risk of getting infected is not increased, but getting COVID infection once you have these problems is true. Heart failure patients, the word heart failure, which is mentioned here, is not the heart stopping, obviously. That's cardiac arrest. Heart failure is when the heart does not pump effectively. The heart's job is to circulate the blood, and to do that, it's a pump. So heart failure patients have weak pump function. And if you don't mind me digressing, just a bit of education about heart failure. A normal heart, left ventricle, the pumping chamber pumps 60% of its content. A heart failure patient would have anything below 40% function. So the heart struggles to pump blood forward. So the flow out of the heart to all the crucial organs is depleted. And hence, blood returning in the circuit to the heart is unable to enter the heart because it's jammed. It's like the Federal Highway in non-MCO times. And that jam leads to collection of fluid or backup of blood in the lungs and in the tissues and all that. And that environment of fluid buildup is a risk factor for getting infection, and the poor perfusion to tissues due to the poor heart function also increases the likelihood of poor outcomes with infections. Diabetes is a major risk factor for infection. Now, again, when I say infection is not getting the infection, it is what the infection could do to you. Diabetes is prevalent in as much as 30% of patients who've been admitted, looking at different populations around the world with COVID infections. Up to 30% of patients have been found to have diabetes. And why is diabetes particularly bad? It has effects on many levels. Diabetes affects the perfusion of blood getting to certain organs because it produces a disease of the tiny blood vessels. So the tiny blood vessels develop inflammation and narrowing, and so you get poor blood supply. That's why diabetic patients get kidney disease, because the kidney capsules, the micro things, don't get enough blood. And that's why diabetics get problems with their circulation in their feet. They have numbness due to nerve damage because the nerves don't get blood supply. and they suffer from risk from amputation and horrible sequelae like that. So diabetes can affect blood vessels, and one major reason why diabetes could be a problem. Diabetic patients also have a very heightened inflammatory response. So if you don't have diabetes and a bug enters you, your body produces immune cells of the right quantum or proportion to go and target the cells and hopefully destroy the infective agent. But when I mean by a profound or exaggerated immune response in diabetics is, for example, if you take the Vietnam War, those of you who are old enough to remember that, when the American forces suspected the Viet Cong harboring their troops in Cambodia, instead of sending a stealth team to seek them out and capturing them in that location, they carpet bombed the entire Cambodia. All right, and that is a over-the-top response, an exaggerated, non-focal attack. So when you get these infections in diabetics, they have a cytokine storm, we call it. The cytokine storm is where a huge explosion of inflammatory cells produce and they go beyond the target which they're supposed to attack. So diabetics have been shown to suffer heightened risk of these kind of reactions. And that is really the key component to the damage coronavirus does. It's not the virus itself that goes around damaging different parts of our body. It's the immune reaction. That's why some people may get the infection and hardly know it and have a very mild infection. But others, on the other hand, may have a very severe, profound reaction and develop lung inflammation, which is the key risk element in this thing. They get ARDS, Adult Respiratory Distress Syndrome. And this is a result of massive inflammation in the lung and fluid and blood pouring into the lung spaces called the alveoli. And this is why patients have to be admitted. Majority of patients who need admission outside Malaysia, like in Europe, is for lung problems, cough, breathlessness and all that. And this is largely driven by these profound inflammatory responses. So these patients end up needing ventilation and breathing support until the whole situation calms down. So diabetics are also increased risk of clotting, and it's been found that in patients with COVID infection, and something peculiar to COVID-19 infection is the heightened risk of thrombosis. Thrombosis is clot forming, spontaneous clot forming. Now, heart thrombosis, you all heard of. Heart attack is when a plaque ruptures and you get a thrombus forming in a form of healing response to that plaque rupture. In these viral infections like COVID, these clots form spontaneously any part of the body. So patients have been seen, young people even, with strokes, heart attacks, kidney infarction and bowel infarction, where the bowel suddenly becomes gangrenous. Okay, this is not a common manifestation of COVID, but it's been much written about. And this begs the question, those of you who are taking Cardioprin or Plavix or blood thinners, you might be fearful, you might have read something that's saying that you maybe should stop your blood thinners. But I would say please continue. There have been reports that there's increased bleeding into the lungs as part of the inflammatory ARDS response, which I talked about. And that bleeding is obviously going to be exaggerated because aspirin reduces blood clotting and you get more bleeding in the lungs. So take your aspirin, because the general perceived wisdom is that your blood thinners are still more important to preserve you from stroke and heart disease if you've been prescribed these two drugs, your blood thinners. So yes, there's increased risk of clot formation. There's also increased risk of bleeding with the inflammation in the lungs. But still take your blood antiplatelet pills. Diabetics have other problems in that very often their symptoms are masked. What do I mean by that? If a heart patient who's been diabetic for more than 5 years usually, if they get a heart attack, very often they may not even feel chest pain or breathlessness, because there is an effect diabetes has after many years on the nerve endings and reduces their capacity to detect pain and certain sensations, numbness and all that, as you know, in the feet. So the same thing can happen, and many patients with coronavirus who are diabetics may not manifest all the warning signs that will take them to hospital and get them attention early. But what happens is they suddenly develop profound lung problems and they go in too late, and there's been quite clearly documented evidence of this, that the symptoms of COVID occur later in diabetics. So that's another negative. A very important point that they've noticed, particularly to COVID in diabetics, is that they found that there's a potential that the virus attacks the islet of Langerhans cells in the pancreas. Now, if any of you did biology, you know that insulin is produced by our pancreas. That sits at the back here, right? And insulin is produced in response to our blood sugar. And that insulin production comes from the islets of Langerhans. Now, COVID has been found to go and target just those islets itself. So patients who are diabetics have suddenly had sudden spikes in their sugars. Patients who have not been diabetic have been presenting with high blood sugars, and the normal doses of insulin and required have been seen to double and treble in many patients. In a certain proportion of patients who recovered from COVID infection, they found that the diabetes has persisted. But this is case reports only. So certainly you must, if you are diabetic and develop this, maintain your diabetic drugs and your insulin, and seek medical help for adjustments of these drug doses that might be required. Especially if there's kidney involvement, then you might need adjustment of your diabetic drugs. Any other questions? No, let's move on to the next question. Obesity and diabetes both reduce efficiency of a person's immune system. I think we've talked about the diabetes angle. But obesity, in fact, obesity has been present in America, in the American spectrum of hospital admissions. Up to about 30% of the patients have been found to be obese. Why that is not entirely clear. In fact, in Italy, as much as I think 35–40% obesity has been identified as a risk factor for hospitalization in COVID patients. I would say that, we do know that obese patients have a greater incapacity to their lung ailments due to the pressure on the diaphragm, and obviously there's a high incidence of diabetes in obese patients, and also hypertension. So all these three factors in combination may be the reason why obese patients are presenting in higher than normal numbers with COVID infection. Do I need to take additional precautions? What precautions? The precautions that people with heart disease, diabetes, and high blood pressure have are the same as the precautions every one of us should take. So, I will repeat these things. Social distancing is the number one thing we can do to prevent infecting people who are at risk. Think about that, and of course ourselves. If we look at the Wuhan data, do you know that 45% of people who developed the infection actually picked it up from from someone who is totally asymptomatic and well. So most of us have a 50% chance of picking up COVID from somebody who to us appears well and for all intents and purposes feels well himself or herself. So yes, it's quite natural to avoid somebody who's coughing and spluttering and keeping our distance. But very often, like us in our practice here, have to be fully on guard for every single patient, no matter how healthy and well they look when they come in. And hence, normally, there's nobody in this room with me, but normally I'll be wearing this N95 mask, goggles on top of this, and if I do a procedure, obviously we wear full PPE until we know the patient status. In CVS, no patient can be admitted until we've checked their COVID status. So we do it the day before, so we have the result to know they're safe to bring in. Because asymptomatic carriage has been seen everywhere. And in the USS Roosevelt, when they tested all the people on board, all the crew, 55% who tested positive had no symptoms. So, you know, listen, it is very dangerous for that reason. That's why coronavirus is the problem it is, because it spreads very easily. It's one of the least harmful of all the viruses. We compare with SARS and MERS especially, where the mortality was about 35%. With coronavirus, we're looking at 4 to 5% mortality, which is much lower than that. I've sidetracked now. The question, oh yeah, asymptomatic people. So yes, so social distancing is important, and I advise everybody to wear a mask when you're out of your home environment. Okay, if somebody's got COVID infection, is coughing and spluttering, and you wear a mask, you still have about well, if somebody coughs over there and you wear a mask, you still have a 5% chance of getting infected. A 70% chance. If I wear a mask and somebody else coughs, I still have a 5% chance. If we're both wearing masks, the risk of transmission is down to 1.5%. So the most important thing is, if you have a cough, wear a mask. Everybody, if possible, should wear a mask in public. So 1.5% risk of transmission if both people wear masks. 70% chance if I wear a mask and you don't wear a mask and you carrying it and you cough. So wearing masks and washing hands. Soap and water is best, and you know it's, you know, happy birthday twice a duration and sing your happy birthday with meaning. Don't spit it out. And soap and water is best. Of course, alcohol, 60% minimum alcohol containing wipes are also handy. Like I have one here, and I have soap and water over there. So I think prevention of infection is the most important thing. And when you cough, obviously, you know, the elbow trick reduces the spread of virus. Even jogging, if you go running and somebody runs past you, there's a good chance that the vapor trail of that person, up to even 12 feet, can infect you. In static situations, 6 foot distance is still is recommended. Cleaning surfaces, it's been shown that the virus can exist up to even a day or two on certain surfaces. Whether they are actually infective 2 days later is not known, because the testing detects RNA, which is the protein that contains the virus. It could be dead, it could be alive, but basically keep your surfaces clean and keep sterilizing them regularly. That's a useful thing to remember. Next question. Okay, who are the people who get, you know, really, really ill from this? I think the elderly are without doubt the highest risk group, regardless of the underlying conditions. it's been shown that fatality rate, if you're over 85, can be up to 15-20%. In China, the cumulative mortality was 15% in all over 80, whereas those in between the age of 30 to 39 had a 0.2% mortality. If you have, there's a question here. Yeah, if you have pre-existing cardiovascular condition of some sort, the risk is about 13% based on China data. Hypertension, even higher. Diabetes, about 9.2%. That means if you suffer from diabetes, you have a 9% chance of being admitted with infection, if you get infection requiring admission. So the more pre-existing conditions you have and the increasing age combine to portend the risk from coronavirus. So from one extreme, an 85-year-old with 3 or 4 risk factors, obesity, chronic airways, lung disease, hypertension or diabetes, heart failure. If he's got the more of those he has and the older he is, mortality can go up to 30-40%. Once you get ARDS, remember the cytokine storm, the profound inflammatory reaction to infection in the lung, mortality is in excess of 80%. So it can be very catastrophic, as you have seen by the numbers worldwide. I have to say Malaysia has done remarkably well so far. Our mortality, case fatality rate, therefore the number of people dying from confirmed infection has been about 1.65%. Look at Germany, Belgium, which is one of the highest, is 10 times our case fatality rate, 16.5%. And UK is not far behind. Reasons for this myriad, I think. It's age demographics, the pre-existing disease prevalence, etc. In Malaysia, currently the figure is about 6,900 infected with 113, I think, deaths, which is very good. The main reason for this, I think, is the fact that we have basically captured anybody with an infection and kept them under so-called lock and key until they've been rendered non-infective. Whereas in many other countries, self-isolation has been imposed, which obviously has not been as effective. How does COVID affect the heart? Okay, there's been an increase in the number of unusual heart attacks seen. What do I mean by unusual heart attacks? Earlier I said heart attacks are usually due to plaques rupturing and causing a blood clot. They found a series of patients where blood clots spontaneously in the artery without plaque. So that there have been few cases like that. The virus can also directly attack the heart muscle. Therefore, virus infiltration and infection of the muscle producing local damage. That's called a myocarditis. You get that with any viral infections, really. And it's been obviously shown here with COVID disease. Patients with heart failure, obviously, with any weakening or inflammation of the heart muscle will deteriorate. But heart attacks also have been occurring in these patients, and their outlook is extremely poor. The cytokine storm, which I keep referring to, the massive inflammatory response, can also damage the heart muscle and produce cardiomyopathy or a heart muscle inflammation that weakens the heart. So that's another mode by which the heart suffers in the COVID infection. I got some questions on Facebook. All right, good question. If a person who has been diagnosed with COVID and has recovered completely and discharged from hospital, does that mean that the person is fully recovered? The current guidelines suggest that if you're at least 10 days post-fever and you're completely asymptomatic, no residual cough and splutter and all that, you're probably already safe and not infective. Some places have imposed a 2-week kind of period where you should avoid social contact and isolate yourself. Some have said that 3 days after your last recorded fever, you're less harmful to your surroundings, but I would prefer to advise people to take 2 weeks off to be safe. The antibodies have been found, and the question is whether antibodies render you totally safe has not been ascertained. But generally, suffice to say, at the moment, once you've got over the infection, you're likely to be okay. The risk of reinfection has not been established, whether the presence of antibodies will protect you from a second infection, etc. I think on the whole, the general feeling is that once you've had it once, these so-called second infections have not been borne out scientifically. So yeah, you're probably going to be okay. How does COVID affect a bypass patient? I think if it's really the same things I said earlier. If you've got hypertension and diabetes and cholesterol, take your medication and be hyper aware of your exposure risks. So really try and self-isolate as much as possible. That means don't go out, don't let people come and visit you, even though you may think they're from safe, so-called protected environments. It's avoiding people is the safest thing to be, because as I said earlier, if you have these preconditions and you get the bug inside you, your outlook is definitely much worse than a normal person. So whether you've had a bypass or angioplasty or heart failure, whatever, for those risk factors which I mentioned earlier, you're at risk. So avoid. Based on the inflammatory effects of the virus, there are theoretical risks that the viral infection could cause rupture of plaque in the coronary arteries, leading to acute coronary syndrome, heart attacks. I don't think there's any good evidence to suggest the virus can promote plaque rupture at the moment, though generalized systemic inflammation, which we keep going on about, inflammation is also a risk for plaque rupture, generally has been accepted. So by that token, perhaps a viral infection can induce inflammation and hence plaque rupture. So again, take your medications if you have risk factors, because that's the most important way of preventing it, not any other way. If I'm infected, do I take longer to recover? I think the question alludes to the fact that if you have any risk factors, do you take longer to recover? Well, if you have these risk factors, you're likely to get a worse infection, and by inference, it'll probably take longer for you to recover. So it's been shown in some patients with, especially with those with heart failure, they take at least 3 to 4 weeks before they're back to their normal selves, if they get through the illness at its peak. Will antiviral medications worsen my heart failure? That's a very good question. There have been concerns with some antivirals. As you heard, our great President Trump recommended taking an anti-malarial drug, hydroxychloroquine, which yesterday in the Lancet was shown in a Chinese study to have no effect. So don't bother taking that at the moment, because the side effects, gastrointestinal and also possibly cardiac side effects, could be harmful. Remdesivir is an antiviral agent that's currently probably leading the stakes as the drug of choice in acute patients who are ill in ICU, in averting ventilation and reducing ARDS and improving survival. But there are lots of trials going on worldwide, and we shall get results soon. Of course, what we all really want is the vaccine, and research is going on at a furious pace in America, UK, China, Australia at the moment, to see who comes up trumps there. Oh, sorry about the trumps. Who comes up on top, and that will really change the complexion of this disease. I've been told from a distance. I got one more question. Can we get infected twice? I think, as I said earlier, there's no clear evidence that a second infection is possible at the moment. I think try and avoid the first infection, and if you do get it, hope you get through it safely and well. And in Malaysia, I think we've been quite blessed in that it's been taken a minimal toll in that sense on our population. Right, I think I've been told from a distance again. I need to call this to a close. Thank you for your attention, everyone. I hope I answered all your questions as succinctly as you would have liked, and I made things a bit clearer for you. Good evening. Have a good weekend.